session, I'm going to do a bit of education and whatnot, and then if you've got anything to discuss, please bring it to the forum. Going forward, actually in that segment, if there's nothing to discuss, I'm actually quite interested to hear your thoughts of how we can try to encourage that engagement, particularly if we end up extending the pilot goes from a pilot to an actual proper kind of service. Because I would be really keen to kind of do that, and I've struggled to kind of get engagement, so it'd be interesting to see your views on that. So to get going, hopefully you can all see that.
Yep.
Fantastic. So, oh, is it not going to work? Oh, hang on, maybe that'll work. Okay. So a little bit of housekeeping. What's come up, as no doubt some of you are already aware, is that we had some issues, what appeared to be that a lot of notes hadn't been being sent to the GP because of this still ongoing problem, almost a year later, of email verification. We just wanted to clarify and kind of make it quite clear our stance as an MDT and working task finish group, is always find it a bit of a mouthful, is that we've informed you about the process quite a lot of the time. There was also warnings on the pharma outcomes. So realistically, if you have not had email verification by the GP, it is your responsibility to ensure that those notes go to the GP in some way or format. I know a lot of you also have good working relationships with your GP practices. So if you do, please feel free to try and give them a nudge to get their email verified, because obviously that would make your life a lot easier. But I think at the end of the day, if you don't do this, potentially, if we find out months down the line that 60 patients, for example, I'm exaggerating, hasn't required an appointment with ENT or required an appointment with their GP and they didn't get it, that would be a significant harm. And I have to do a massive review, probably be up at the South West London Quality Board. It is a significant problem. Okay, it's not just, oh, I'll do it when I want to do it. You must do it. There's no kind of grey line about this. I would say it would be also really good practice, particularly if you are having problems and maybe you are posting it at some point later that week when you're doing them as a pile, is that you actually document when you send the document if you're not sending it via email. Because if you send them in a batch or you tell us, I've sent it, but you've got no proof of that and you've not recorded it anywhere, we'll still have to do that harms review. Okay, because we have to have proof. That's what it all comes down to. All right. Hopefully, if you have any further ongoing issues, you're already in contact with Nita about this, or it doesn't apply to you, which would be the best thing. Sorry, if I occasionally turn around, my dog is in my room with me and just trying to destroy my office at the moment. I don't know what she's got. Okay, so I'm going to talk about tinnitus. So tinnitus is a patient who's hearing a form of sound and that's not produced by an outside source. They're not mad. It is something we probably still don't fully understand, but it's really thought that it's really an overactivity of the hearing pathway within the brain. It can be both ears. It can just be on one side. A lot of patients can't delineate which side it's from. So they kind of might say they don't know, or they may say it's more midline. Often when they don't know, it often means it's bilateral. It can also be pulsatile and non-pulsatile. Non-pulsatile can be a variety of noises. Obviously, the most common is ringing or buzzing, but people can have quite a cacophony of kind of sounds going on. So they have, I had someone today who's having like a thump happening. It was very clear it wasn't pulsatile tinnitus. I've had people say it's like a lorry's driving past. It is very, very different. It can be constant and chronic, and it can also be intermittent. And it's a really common problem. And as we're doing potentially earwax removal or even the hearing checks, you're going to come across it. 1 in 8 adults suffer with tinnitus. Over 1 million GP appointments are about tinnitus and how to manage it. It is much more common in the older adult, but it can actually affect any age. I do see children in my clinic with it as well, quite frequently. And it is commonly associated with hearing loss. But if you have really rubbish hearing, it doesn't necessarily mean your tinnitus is severe. And if you have severe tinnitus, doesn't necessarily mean you have severe hearing loss. The two don't necessarily correlate in terms of if your hearing's deteriorating, doesn't mean your tinnitus is necessarily going to get worse. So what causes it? As no doubt you know, probably better than me, there's many medications. Your NSAIDs, your diuretics, your ACE inhibitors. I mean, the list just goes on. And I think you have to kind of do a pragmatic approach to that, because obviously a lot of the time you're giving those antibiotics or those painkillers or those antimalarials for a reason, and that reason is quite a good reason. And it hopefully would be that when you stop the medication, the tinnitus disappears. Obviously, if it's something like aminoglycosides, that's probably if it was more giving intravenously, which is obviously why you take the levels, because that can become so toxic it actually permanently damages the hearing, let alone just causing tinnitus. The common one that everyone knows is obviously exposure to loud noise. When you were younger, you're at clubbing, you get temporary threshold shifting. So you get a little bit deafness, and you also get that huge amount of ringing, but on the whole, the ears recover. You can have it after, if you get sudden hearing loss after a virus. If you get sudden damage to your hearing, you're probably also going to get tinnitus. I've seen it happen just after a simple bacterial infection. I've had a clinic patient today who had what seems to be going around a lot at the moment. I had this awful virus at Christmas, is how they keep talking to me. And it's probably they're having some sort of bacterial or a viral infection. It can even occur after a really big, stressful life event. And commonly, there's absolutely no trigger whatsoever. So when should you get worried about tinnitus? When do you actually need to act on anything, or advise your patients that you're seeing that they perhaps should go back to their GP or signpost them to other services? So unilateral tinnitus, particularly if it's been more persistent for 6 months. If it's unilateral but intermittent and the patient's young and they don't have any other red flags of which you have copies of, then they're not probably going to have anything wrong with it. It is still nice and NHS guidance, if they have a unilateral tinnitus, these patients should have an MRI scan. What we're looking for is something as chances of it happening is less than 1% if tinnitus is the only symptom. So it's not a 2-week wait wall referral. You also need to be concerned if they've got asymmetrical hearing loss on the same side that are reporting tinnitus. So if you do a hearing check and, for example, they're complaining of right-sided hearing loss and they've right-sided tinnitus, and you also see that they've got right hearing loss but their left ear is normal, or there's a big difference by 3 or 4 squares, that patient needs to be referred on for a formal audiometric test and potentially to ENT or the equivalent, which is sometimes audiovestibular medicine. Another worrying factor is if they've also got tinnitus and facial numbness. That normally means there's something big pressing on the trigeminal nerves and nerves in the brain. If they have vertigo on the same side, and it's not just I feel a little bit lightheaded, it is I'm having spinning when I'm moving in that direction is pretty consistent. And headaches, vision changes on the same side, and obviously they've got nausea and vomiting, but the lesion has to be quite big. So why are we worried about these particular concerns? This is when we're looking for something called a vestibular schwannoma, otherwise known as acoustic neuroma. That's its other name sometimes. It's a benign lesion that generally grows on the balance nerve. You can have neuromas of the facial nerve. You can have neuromas of the cochlear nerve, but actually they're less common. Most of the time it's a vestibular schwannoma. And these are benign lesions that are often incredibly slow growing. And the majority of the people, you don't actually do anything to them at all. You just watch, wait, and review. And you only offer them treatment if it grows. And if they have no other symptoms and just asymmetrical hearing loss, and you find it frequently, they're just what we call intracanicular. So they're very, very tiny. And the likelihood of them growing over a 5-year period is only probably about 30%. And they get serial MRIs. If there's obviously someone you pick it up is quite young, it's very likely they're going to have treatment at some point, just because of the amount of time they're living. They've got another 40 years to go. If they're 70, you pick this up, sometimes I actually have a very realistic conversation with them and say, look, you're fairly asymptomatic. What's the point of scanning you again? We'll just scan you if you have symptoms. And I'm telling you this to try and give you the background of kind of why we're not always that worried when they have these sorts of symptoms. It's more if you were concerned that they may have pressure on the brainstem. So that's when you get the headaches, the nausea, the vomiting, particularly in the morning, because they sometimes, very rarely, can present as very big, large vestibular schwannomas. And if they're putting pressure on the brainstem, now, yes, that is an emergency. But all the others, it's all very much routine. And that's because the treatments are not curative and they can cause as many symptoms as the lesion itself can cause, which are unilateral tinnitus, facial numbness. That is the key. If their patient has facial numbness with their tinnitus, there's a high chance they got a reasonable size vestibular swallower, often not large, but reasonable. And that's the reason why we need to be concerned. So when you're seeing a patient with tinnitus, you can't just write down reporting tinnitus. You actually have to ask them a couple of questions about it. Is it one-sided? Is it bilateral? How long you've had it for? Have you ever had it investigated? Because, for example, you might be seeing people who are in their 80s, 90s who've had it investigated. And if it's not changed, they don't necessarily need to act on it, but you need to document that conversation. So the other form that we kind of do kind of investigate, but I would say I'm kind of obviously sounding a bit unsure when I'm saying that, is because most of the time when you find something that's causing pulsatile tinnitus, there's not a lot you can do about it. It's really common in patients who get migraines. So firstly, I'd definitely be like, you need to think about your migraine treatments. Uncontrolled hypertension, that's obviously an easy one. Hypothyroidism, anemia, atherosclerosis. It can just be an altered awareness of blood flow. So particularly people report it at night and maybe just on one side. That's probably because they're lying on that side and they're causing compression of their arteries and they're getting the transmission of the sounds. And you're more likely to hear it, A, because you're directly pressing against your pillow, but also because there's not much else going on when you're trying to go to sleep. Some of the things why we actually scan these patients, so they often will get what we call a CT angiogram, is we're looking for benign idiopathic hypertension, which is better with an MRI, but you can sometimes see some clinical indications on the CTA. An arteriovenous malformation, which most patients don't want to do anything about, but you would have to then refer them on to neurosurgery. But the AVM, arteriovenous malformation, has a significant impact on life. So you have to inform the DVA. DVLA, you have to inform your insurance companies if you go on holiday, because obviously there's risk of ruptures, and it can have quite significant consequences if you do find one. We sometimes find a persistent stapedial artery. Now, why would that suddenly start to cause a problem if it's been there since birth? Is difficult to kind of really understand that one, but it's definitely seen to be dilated in patients reporting pulsatile tinnitus. But you wouldn't do anything about it because you're going to cause many more problems by trying to do something. Pregnancy is obviously an obvious one as well. But certainly if it's persistent for more than 6 months, that definitely needs an investigation as well. So treatments. So what you can do if someone's struggling is actually point them towards what's called the British Tinnitus Association website, which is actually easier in tinnitus.org.uk. These patients need counselling, they need CBT. It's really useful for them to do mindfulness meditation. It not only gives them their sort of mental health break from the tinnitus, but it gives them their kind of power over their own body and control. And mindfulness and meditation has actually been shown to, you can alter your own blood temperature, for example, and you can show that you can relax the muscles, and that can really help with the sort of management as well as the mental health benefits. It's all about good, healthy habits, sleeping regularly, regular eating and drinking, exercising. You can have noise cancelling devices. So the tinnitus therapists in the hospitals can provide a hearing aid style that actually constantly plays in white noise, and that can help drown out the tinnitus. Sometimes just having a hearing aid and therefore improving your access to sounds can make the tinnitus more manageable during the day as well. Playing music at night in the room, you can get special pillows that actually have speakers in them. You can have a speaker like an alarm clock, and they can play lots of different types of sounds. People quite frequently like listening to white noise. Whale music is a popular one, and sort of rivers and things like that. And it's kind of tuning out the tinnitus. And as I said, improving access to sounds with hearing aids. And it's really important to make sure the patients understand that their tinnitus intensity will vary. So if they become low in mood or they suffer with a depression, the tinnitus will probably get louder. If they have anxiety, they don't sleep well, they're feeling stressed, or they've just got a busy life, in that I find that some patients, when you tell them it could be because you're stressed, they don't really like hearing that, because most of them don't always feel that they're stressed. But actually, when you point out to them, perhaps they're managing 5 children and 2 jobs and everything else, and perhaps they've just got a lot on their mind, and you phrase it that way, they kind of understand. Because realistically, they probably are stressed and under pressure, but they just don't see it that way. Or if they become ill. And it's really important to point out the link between that and mental health, because when patients get depressed, tinnitus will get worse, and tinnitus itself will make the depression worse. And patients can become suicidal from tinnitus. I've not actually had a patient who's done that, but I have had patients who have come very close to it, and it's difficult. But that's why it's really important to try and get the message across early, and also about seeking help early before they sort of hit the rock bottom. Okay, that's the tinnitus side of things. Any questions?
There's nothing in the chat, Tori.
Perfect. Thank you. Okay, so I'm going to talk briefly about secondary care referrals. The reason I did this is because I was looking at some of the patients that could move from St George's into the pharmacy system. So I was reviewing all our patients who had been pushed into the George's Wax Clinic, and there were quite a few that obviously had failed community microsuction. And one of the things I'd noticed is that when the GP did actually attach the sort of PDF documents that you guys are providing, sometimes there was actually very limited information about why the patient was being recommended to be referred to secondary care. So it's just a kind of gentle reminder. It's also, I'm very aware that you all equally get really frustrated when the GPs themselves don't tell you why they're referring the patients on. So please just try and make it clear what the reason is for referrals. And the other thing is, I'm sure all the patients being referred for earwax removal are just really hard wax that can't come out. But please do remember that not all earwax needs to be removed completely. It is okay to leave a small amount, and that patient doesn't necessarily have to go to secondary care to remove the last small bit. I have a case that I picked up, and this was a patient referred, I'm assuming, because of earwax or couldn't get it out. And I was probably a little bit surprised that this one was referred onward, because the earwax looks very lateral to the eardrum, and it's very circumstantial. And I'm not quite sure, I don't actually know which pharmacy it came from or who it was. And I just was maybe interested in people's thoughts. Would they have managed that differently? Would they have actually referred it on? Because I assume you've come across something a bit like this. And it's just to kind of figure out what maybe everyone's confidence is around removing wax at the moment. So I suppose my question is, would you have removed this, or would you have referred it on? No silence.
You can pop your answers in the chat if you want to, and I can read them out to Tori. Referred on.
Okay. Can you explain why, just so I know? Like, what would be worrying about the picture, really? Rasha, you can type it, obviously.
It looks too near the tympa membrane.
So I would say that's quite far out, because you don't necessarily have to go for the middle straight away. You would actually start, I can't do this in the full screen, you start more laterally, lifting the earwax up like that. And that bit, the bit right at the front, is more closer to the front of the ear canal than the eardrum. I understand maybe you wouldn't be wanting me to go the bit in the middle, but you could gently tease it out and then you wiggle it out. And that's, personally, I think that would have come out. So it's just maybe to think about, when you first have a look, maybe just try to tease the edges to see and whether you can kind of wiggle it out, rather than necessarily going straight for the deeper part, because often you'll find the deeper part will then come out as well. Can we get a clear image? Good. I'm glad you know, as I mean, everyone's confidence is going to be different. unfortunately, it was a photo I took, and I didn't realise how bad the quality was of the photo until I literally just put it into the MDT presentation yesterday. I put it up mainly as a kind of discussion point and to kind of trigger thought processes around it, and also to kind of maybe share with the group different confidence levels as well that obviously people are going to have, and because it's useful to do kind of peer group learning, not just me saying, yeah, I'll take that out because of course I would, because I'm an ENT surgeon, but I'm not doing the community service. So it's nice to see that it's a mixed bag. I suppose that's a good thing. Okay, what else have I got in there? So otherwise, has anyone got any case studies that they would like to share? Have they had any interesting things? Even if you haven't got a picture of it, that's fine. It's a case or a patient who came, or they were difficult, and maybe a good news story. Maybe someone patted you on your back and said, thank you, that was amazing. Anyone willing to share anything that's happened this week or last week? Oh. So this is the bit I was asking if anyone has any ideas for, because the last several MDTs I've asked this question, and I think I've had one MDT when someone bought something, and it'd be really interesting to know. A lot of happy patients, thank you. Nice to know. That's what we like to hear. So maybe that's the thing. Maybe they're all happy, and so you've not had any problems. But it'd be interesting to know your thoughts on maybe how I could improve that engagement to try and do that. How can I encourage that process? Because you can ask people, but they don't always provide that, because obviously it's voluntary. If there's nothing anyone can think of now, maybe you can email me or Nisha later as well if you have a think, because obviously it's an evening session, so I understand that's harder. But we did put it in the diary. I know I didn't necessarily release the agenda, so yes, I can try and do that, but it could be that at each meeting I have the first 5 minutes is everyone has to discuss one thing, or if we go to a slightly bigger group, it could be a different area is their responsibility to discuss something that week, and then it's the next MDT, it's another one, so it shares it out. I don't know how to encourage you guys to take a shot at whatever you're doing and share it, really. All right. Is there any other problems, concerns that anyone's coming across in the last few weeks that they want to raise? I know we're thinking about coming towards the end of the pilot. No. Nisha, is there anything you'd like to say?
Yeah, I was just gonna kind of bring up the email that your contractors or you would have been copied into from Amit, from the LPC regarding the future of the pilot. So as per the comms, we will be winding down the service on the 31st of March. We're hoping to hear from the ICB next week. But until then, we can't really say whether it's going to go ahead or not. But we still have to wind down irrespective, and then kind of re-procure the service, because this is what terms and conditions of the ICB are. So, but we'll send out a comms, and we'll also have to have a strategy in place where we need to switch sites off so that you can honor all the booked appointments that you've currently got, because we don't want to be in a situation whereby you've got bookings beyond the 31st of March, because the service is going to be finishing on the 31st. So just watch the space and watch the WhatsApp group, because there'll be lots of updates coming through regarding that folding up process. But yeah, fingers crossed that it will carry on in some shape or form after March. Abid?
Hi, Nisha. I just want to mention one thing. Since pharmacy first started, I know this otoscopy is for under 17. From 1 to 17. But the thing is, some patients are just being sent to the pharmacy to go to pharmacy and get your ears checked. We can't deal with them under pharmacy first, and we can't deal under TIMPA. And then we have to send patient back to the surgeries, and then patient says, "You guys are playing with us like a ball, sending here and there." So in that case, what should we do?
Well, I know that you definitely can't see them under the banner of this service.
Yeah.
So I think this is a pharmacy first question, really. Okay, let me take that away, Abid, and I'll get back to you tomorrow.
Yep. Thank you.
Okay. Does anyone have any other questions? Sorry, Tori, you're about to talk. Hi, Aru.
Sorry. Hi. I just had one question. We had a lady in a wheelchair, an elderly, I think she was in her 90s, and she was very agitated and didn't really want her ears done. So obviously we didn't against her will. But I think she was referred into the system before and we had the same issue. Is there any service which patients like this can be offered?
I think the problem is, my experience sometimes with these type of patients is they may have some cognitive dysfunction. It is not always diagnosed. There's not always a family awareness of that as well. And I would probably have as much problem, and I have had patients like this in clinic, even if they can get onto a couch. I mean, I've been on my knees in a clinic room on a pillow trying to get earwax out with a microscope, let alone just a Timber device for that type of patient group. But what comes down to it is that if they're too agitated, you can't do things against their will. If they've got severe dementia and therefore you're trying to do it in best interest, you can have an attempt. However, if they're moving their head, you are going to probably cause more harm and probably not going to be able to remove their earwax. And at the end of the day, they probably need, people communicating them in a different way, and may need a different way of improving their access to sounds than what they've currently been provided. So I don't necessarily, the only other option is they get referred into ENT, but they'll probably have the same problem. But what I'd probably be doing is having a sensible discussion with them. And I wouldn't expect you to do that, about maybe you have to draw the line under this surface. But equally, that's the GP's responsibility. So I think you'd have to say, look, we've tried twice to do this, but actually each time she's refusing, she gets agitated. We don't think it's safe to do. If in future you still feel that's another go, then refer on to ENT, but it would be probably a waste of the patient's time unless she agrees and she's calmer to have the procedure and to get re-referred. And so basically that's a lot of typing you've got to do on go back to the GP to explain where you're coming from, really, because they don't always understand. They just refer and forget about it and don't always apply common sense.
Okay, so back to the GP with explanation.
Yeah, I think so, because you've tried your best, haven't you? You've tried twice. It's not like you refuse to see her. It's not like you can't physically do it because you've got a device that actually can work around the chair. It's actually just on that particular patient's, she can't tolerate it.
Yeah, so as soon as you come anywhere near her head, she would just, turn her head. So it wasn't
exactly. Yeah, exactly. And you're going to do more harm. It's a metal instrument if they're not compliant, and you just have to accept it. And that's what I would often have a conversation with. I spend most of my life as a consultant having sensible conversations with people. And I think that's my job most of the time. But sometimes that type of patient will end up with us for us to do that.
Okay, that answers my question, because I was just looking to see what do I do next. I mean, obviously I wouldn't have done anything, would treated her, but how do I signpost her? That was my
exactly.
That's fine. Thank you.
No worries.
Oh, have I raised it again?
Hello.
No, you're fine.
Hello.
Hi.
I'm just calling from Vansud Pharmacy. I just
know about. Like, I booked it for like until March, all the people's, and I'm still receiving the farm outcome referral. And what can I do if they didn't like? They will not. When it will be stopped? Like, and when will it will be like? I will not booking for like the referral, because it's sending and sending all the papers, and I'm booked for 10th of March as well as until.
Nisha, you.
Yeah, sorry, Meet. So if I understood correctly, you're saying that you're currently booking in for the 10th of March?
Yeah, I booked it all the people's until March, 10th of
Okay.
March, and still the referral is going on.
Yeah,
So what can I
you
do?
will.
Yeah, when it will be stopped, the farm outcomes.
Okay, so
referral.
you will still receive referrals until you are accredited on farm outcomes. So I'm going to make a note of your pharmacy, and I'm just going to put a note in my diary to check in with you next week and just see how far you're booking into March. And if you're approaching kind of the end of March, then I will switch you off on farm outcomes so you don't receive new referrals, and then you can just honor all the booked patients that you're receiving currently.
Yep, thank you.
Okay.
Harsha? You're still on mute, Harsha.
We can't hear you, Harsha.
You're not mute, but we can't hear you. You can type it. Yeah.
Sorry, Nisha.
Hmm.
If you're going to switch us off, any pharmacy off on farm outcomes,
Yeah.
and if you're probably doing it, say mid-March or something, we can still do the entry till end of March, right? We
Yeah,
will just
you
not
can.
receive referrals.
Yeah, exactly. You can do
Okay, that's
everything like normal. You just won't receive new referrals from
Receive
general
any
practice.
referrals.
Yeah.
And obviously,
Sure.
some of you
Thank
may hit that before, so you need to keep Nisha updated. If as soon as you're fully booked to the 31st, or maybe make it the 30th, just in case. You need to tell her so we can switch you off so you don't get any more referrals.
Yeah,
Okay.
it might be a case that some pharmacies get switched off earlier than others, but please keep me informed, because if you start booking after the 31st of March, we won't be able to honor those appointments, and also you won't get paid, and it will become a bit of a a nightmare. So yeah, just keep me
Sure,
updated.
Sure. Thank you.
Nisha, Harsha just asked about what the comms to the GPs are going to be around the ending of the service.
Yeah, so I think they will be informed. We need to inform them, of course, and we'll work through that during our task and finish group, I think, Tori.
I suspect even with the best comms in the world, some things will still sneak through, but as hopefully as long as you're switched off an appropriate time frame, if you keep an eye on it as your own pharmacy, then you won't hopefully get any overspills that will affect you personally on a business level.
Yeah. Okay, we've got Aru.
Yeah, so just following up on the booking of appointments, if we had anybody in the last week of March who needed a follow-up, how do we deal with that?
The follow-ups will still be honored, so you can still do the follow-ups, but just no new bookings.
Okay, so after the 31st of March, we're still valid providers of Tympahealth.
No, you won't be.
Get affected by. So how do we do follow-ups? If we see a patient in the last week of March who needs a follow-up in 10 days or 2 weeks, what do we do with them?
You'd probably need to talk about that. So, Nisha, can you write that as a thing to talk about? But I suspect what we'll have to say is if you think they need follow-up, you just need to document as normal and send it back to the GP. There's no rescue service to mop that up.
Okay.
And you don't want to be doing 16 million follow-ups when you're technically the service has ended. You know, it would be someone that you might only think needs one follow-up. you've got to use a bit of common sense. But I definitely would be like, yeah, unfortunately, that when you end a service and we have to go through tenure again, just the way the politics works, no one wants to do that, but that's the reality.
Yeah,
And it means patients will lose out.
We just need to be mindful of that.
Yeah.
Okay. Thank
you. Next we have Ganesh.
Hello, Nisha. A small question. So I had a very odd experience. So we have referred to the GP some legit reasons to assessment. That was in last year, and GP wasn't followed up. And then patient rang us 2 weeks ago. I haven't followed up. What happened? I've been seen, and then when he contacted the GP, he said we never received. And then I sent the referral back through electronically and via email, chief. So I'm not sure what to do in the scenario.
The reality is that's with the GP and the patient. If you can prove that you sent the email, that you did all that, you know, it's completely above board, and I'm sure it is. And actually it's also the patient's responsibility, or to some degree, that you've given the information as well. You know, if the GP is giving you the wrong email address, but the patient can complain to the GP practice and they can investigate it. We could ask Aditi whether you should raise an MCAD, but I don't think we can unless the patient's particularly made a formal complaint. But we might just need to check with her on that one. I'm not sure.
Yeah, I printed the email that I sent last year, but still he's not happy at all. He's ended up with a complaining with us.
But that's not your response. You know, all you can say is you have to take, if you feel frustrated by that system, you actually have to take that up with the GP practice. They should have a complaint system in place. Because from my end, I sent the GP practice in the agreed route the information that was required.
Last question is, so when we send to the further assessment with the GP, even electronically via email too, so how many days patient would expect call from the GP?
That's very individual in each GP practice. They'll be handling their paperwork very differently per every practice. Some of them paid, you know, they get salaries who go through their admin. It's like checking their pharmacies, and not pharmacies, checking their drugs and their medications and their blood. It will be part of their admin. The only way you'd know is if you ask that particular GP. Aditi might know what the average is if we ask her. I personally don't know, but we can certainly ask and see what that.
She's joining, Tori, in 2 minutes.
Oh, well, then you can ask her then.
Yeah,
it's a good question. As a GP, she'd be more likely to know the answer.
Umesh?
Hi, sorry, I missed the beginning of the meeting. So if I've asking something that's already been said, I apologize. But looking at the service referrals and consultations that us guys have done, it's incredible. You know, I really congratulate everyone. Obviously, it must have helped the ENT department so much to have, you know, side-loaded these mundane referrals onto us. And Nisha, so you're saying that the ICB are considering, you know, to keep this service ongoing. What kind of hope have we got?
Your guess is as wild as mine. So
it's really difficult.
There's nothing bubbling in the background or anything that, because honestly, I mean, I you know, the doctors, the GPs, everyone have been so, you know, welcoming the service, and they're so happy that we're so accessible, that, you know, to have something like this go is just a shame. It really is.
We fully agree with you. You are preaching to the converted, and I suppose that's the problem. There is some discussions about, you know, what it might look like, whether there's a kind of reduced type of service that could be running, but we just don't know. Unfortunately, the ICB is under humongous strain in terms of finances and which services do and don't get through, and we are under, you know, we just have to wait to see. We've working tirelessly, particularly DT behind the scenes, of trying to push our agenda. And hopefully, I think Nisha shared it with the team's link for the meeting, that the South West London oh, I don't know what to call it now, but the kind of evaluation of the whole service. And please have a read. It's all your hard work going into it, and hopefully you can just see what's happened and the impact that you've all had.
Thank you.
Didi, we had a question for you because someone had a patient who had come in and complained that, and Umesh, tell me if I got it wrong, that the GP never contacted them about what they needed to do, and the GP is denying the fact that they received the information. Umesh has the email, and I think he sent it by email and another way, can't remember what the other way was, and has a record of that, and has sent it again last week, the notes he recorded, but the patient's still not happy. He was asking, one, what's the general turnaround for an average GP to look at that sort of admin? I think for interest's sake, but I was also suggesting that actually, from my perspective, that patient needs to go to the GP to raise that concern, because Umesh has done as much as he can.
So are we confident that the information has got back to the surgery?
Umesh, you have to answer that one, I'm afraid. It sounded like it from what you were saying.
It was Ganesh, sorry.
Oh, sorry, I thought it was Smash.
That's okay.
Sorry, Ganesh.
Oh, sorry, I was stuck in the traffic. Yeah.
Ganesh, we're just asking, with the information that you sent back to the GP, how sure are we that it got to the GP? That's what.
So yeah, so when we sending the emails through NHS email, so we have read notification and delivery notification. Clearly, we can see that email was delivered to the surgery. One of the reception team has been has read the message. So after that, so my question is, so how long the patient would expect the call back from the GP if some legit reason, if GP needs to reassess the patient?
So different practices will manage it in different ways is the short answer. The reason I was asking was, are you confident it's got back to the GP, is, there have been some practices where the email address hasn't been verified, and therefore the alert's coming up on Pharma Outcomes for you to print the discharge letter. So just wanted to make sure it wasn't one of those where there's that issue that's come up. If you do you think it's definitely got to the practice itself?
Yes,
in the normal way.
One of our regular, we do use quite regularly. We use the email. They operate regularly.
Fine, okay. So in which case, I think every practice is different in terms of how they manage their paperwork. I would certainly expect that within a week of you sending it, that they would get through that paperwork. But there's not one system. So, different practices will manage things in different ways. Was it something urgent that had to be dealt with, or is it something that was routine?
No, something like routine. Most of the patients ask whenever I refer to the GP, then they will ask. That's the most every patient asks to whoever refers. So
yeah, okay. So it sounds like you've done all the correct things. So as Tori's said, that the best thing to do is to go ask the patient to go back to their GP, and they could ask the receptionist if they've received the paperwork in the first instance, and then how long it's going to take for the surgery to process it. So I would direct the patient to the practice reception so that they can ask those questions directly to the surgery.
Okay, thank you.
If you don't have any luck, or if you're struggling with anything, then let Nisha know, and then obviously we can, if there are any specifics then that we can help with, then just let Nisha know, and I can help you with that direct case if there's any issues.
Yeah, definitely I do.
Thank you.
Any other questions?
Yeah. No.
Perfect. Didi, anything you want to say?
I think, Tori, you probably already said it, but just to reassure all of you, we are trying our hardest to see what happens post-pilot. I know that it's really frustrating because you want a firm answer now. There are some big corporate meetings going on next week. There have been already several meetings about it, but there's specific boards and things next week to discuss it. And I heard as I just joined that, Tori saying about the finances for South West London, everywhere, as you know, is pressurised in terms of finances. But there is a commissioning team, which is not me. There's a whole proper commissioning team that is involved in the business case for the future. And I know that it's something that is being prioritised, but we just can't be sure what will happen until those meetings go forward and the finance team and everyone decide what happens next. So as soon as we know, we will update you all. But in the meantime, I think if you just work with that mindset that the current patients you have, we need to get through before the 31st of March. And then obviously, as soon as we have the details about the future, we will let you know. But we will just want to make sure that the patients you currently have, you get safely through by 31st March. And the other thing I just wanted to say was, as Tori said, the evaluation is live. There is lots and lots of excitement about it. You might have seen that the chief pharmacist, I think, has commented on it in the report itself. So we've got Anne Joshua and David Webb have put their comments about it. And there are lots of other places that are excited about it. You might get contacted by it. And the South West London comms team and the St George's comms team and others are all aware as well. So there's lots of excitement about it. So thank you very much for all the work that you've done. I think this is, obviously you've done this for the whole country, to be honest. So let's see what happens next. And my final point was, if you're having any confusion, for those of you who are involved with Pharmacy First, if you're finding there's any confusion between Pharmacy First, Tympahealth, CPCS, let us know so that we can work out how we can make sure that the different work streams are working effectively. I'm guessing that there will be some lack of clarity sometimes between the three. So if there's anything we can do to improve that clarity, then let us know. I'll stop talking. Happy to take any questions, but appreciate it's very late as well.
There was just a question about will GPs know about the service coming to an end? And so we'll be writing to them.
Very good question. So yesterday, that is exactly the discussion I had with the Sai as Merton place lead and with Nicola Jones as Wandsworth place lead about exactly that we need to get some comms out to the practices. I think everybody's waiting for next week, but irrespective of that, we do need to get some comms out. So yes, it's very much on the list of things to do. And all the practices will be informed. We're sort of hoping that we can see what happens next week, but we have to tell practices by the 31st of March that the current pilot ends anyway, so it'll go out, that comms.
Oh, thank you. Does anyone have any last questions before we close the meeting? No? Okay.
Sorry,
Thank
Nisha, just
you.
last thing. Sorry, is it possible if you can CC to the pharmacies who are part of this project as well when you're communicating the surgery about the service, so we are on the same page?
Yeah, so the comms, normally we have a dedicated way of communicating with the practices, but the day it goes out, we'll make sure, I'll send it to Nisha as well to make sure that everybody's got it at the same time.
Yeah.
Perfect. Thank you very much, everyone. Again, as we probably won't have another MDT in March, so this will be the last time we do this. And thank you for turning up on an evening. I know it's hard sometimes, and it's much appreciated. And I hope you found it useful. And hopefully, fingers crossed, we will still be seeing some of you again following year. Or later in the year, maybe I should say, not the following year, because that's probably fine. All right. Thank you very much. Have a good evening. Bye-bye.
Thank you.
Thank you very much.
you.
Thanks.
Bye.
Thank you very much.